Hello, everybody, and
Not yet.
welcome. Not yet. I got a thing that says
Sorry. So
Now we're good.
All right. Good afternoon, everyone. Welcome to the next budget hearing for the Health and Social Services Subcommittee on Appropriations. Today, we will be hearing the overview budgets of the Departments of Health, the Departments of Human Services, and the budget for the Maryland Health Benefit Exchange. Just a couple of housekeeping things before we start. Generally, the way we work is we will have the analysts present their analysis, have committee have questions. If they have any questions, we'll go to the department for their response. Any questions following that, and then we will go to anybody who signed up in the public to testify as well. Just as a note, we will be limiting the public testimony to 2 minutes per person. Just want to make sure everybody's aware to keep your comments to 2 minutes, and I will very gently and politely cut you off when you get to that point around that time. Also, just as a reminder, everyone, that this is being live streamed and everything said and typed is in the public record. So just be mindful of that. Finally, just as a reminder, the overview budgets are just that. They're overview budgets for these two large departments that we will be also hearing more detailed budgets depending on their specific agencies, commissions, and sub-departments as we move forward in the next few weeks. And so we will have multiple opportunities to tread over this territory a couple of times. Just keep that in mind with regard to both questions and time. So with that, I will go ahead and we will have our first budget presented, that being the Maryland Department of Health overview, and the analyst Ann Wagner. I believe she will share her screen with the analysis, and we will move forward from there. Take it away, Ann.
Thank you very much, Mr. Chairman and members of the committee. I'll share my screen. Okay, you can all see that. Great. So starting off with the Department of Health fiscal 23 budget overview. In this first chart shows the past 5 years of the department's budget. In fiscal 23, the allowance shows a net decrease of about $625 million or 3.4%. And that's mostly due to COVID-19 related spending coming out of the budget. I will note, though, that general fund spending does grow by about $650 million in fiscal 23, and part of that is to backfill that federal spending. I'll jump ahead to on page 5. This shows the department's budget by use of funding. More than 85% of this budget does support healthcare in different forms. This is mainly through the Medicaid program that accounts for 66% of the department's spending. But then there's also the behavioral health services and community services for people with developmental disabilities that account for another 20% of the department's budget. So then moving on to the proposed change in the fiscal 23 allowance over fiscal 22. This table shows an itemized list of major changes, but of course there will be more detailed discussions during other budget hearings for each of the department's specific offices. So I won't go too far into depth with this. I would just highlight that across the department, regular personnel expenses increased by about $8.4 million, but this doesn't include things like cost of living adjustments, annual salary reviews, and some other personnel adjustments that are budgeted centrally in the Department of Budget and Management. The other thing I'll highlight is that there is a deficiency in adding money in fiscal 22 for overtime expenses. That's about $8.9 million. And that's mostly for personnel in the state health facilities. Moving on to, I'll jump ahead to the Behavioral Health Administration. Here, there is funding to cover the 3.25% mandated provider rate increase. And then the health department is also accounting for recruitments related to the ASO in fiscal 23. But you'll see that the largest change in the fiscal 23 allowance is this reduction of almost $340 million. And that's shown as it was a deficiency adding funds in fiscal 22 to cover behavioral health reimbursements in service year 21. So that's the largest change in behavioral health. But again, that'll be discussed more in depth for that analysis. Moving on to prevention and health promotion administration. This is the section of the budget where you're seeing the most COVID federal funds, or a lot of the COVID federal funds related to CDC grants for testing, vaccine efforts, and other uses like that are coming out of the budget here. So you're seeing a large decrease of $473 million or so. I will note, though, that there's also new funding coming into this agency for school-based health center grants, and those were formerly administered by MSDE, Maryland State Department of Education, but they're now moving to the Maternal and Child Health Bureau. And then under Medicaid, there is the 4% mandated provider rate increase that's also funded in fiscal 23, and the same is true for DDA for their 4% provider rate increases. I will point out, though, that this provider rate increase amount includes a rate increase for dental services and then also for physician rates. Specifically for the physician rates, it increases to cover 100% of Medicare rates, and in past years that was closer to 93%. So we just wanted to note that in the fiscal 23 allowance. So then moving on to discuss some of the federal fund stimulus that the state has received on page 11. The largest source of federal aid for the Department of Health has been a 6.2% enhanced federal match that has been in effect for the length of the national public health emergency. And this enhanced matching creates general fund savings and will be in effect through the last quarter in which the national public health emergency is in effect. So when the budget was introduced, it was based on the assumption that the public health emergency was going to end in March 31st of this year. But since then, there's been an announcement that it's actually extended into mid-April. So this brings the enhanced federal funding through the end of fiscal 22 and will now end at the end of this year, June 31st or 30th. The next thing I'll point out is there's also enhanced funding allocated through the American Rescue Plan Act, specifically for home and community-based services. So that's 10% enhanced funding. And for this funding, it must be reinvested in home and community-based services. There was language in last year's budget that 75% of this funding must be used on a one-time rate increase. And so I'll talk about that a little bit more in the issue section of this analysis. But the state is receiving this 10% enhanced match from April 1st of last year through March 31st of this year. So then moving on, I did want to point out some of the Medicaid enrollment trends. So part of that receiving the 6.2% enhanced match is that state Medicaid programs are required to pause disenrollments from a program. And so because this was extended through fiscal 22, the budget assumed that enrollment would start declining as eligibility redeterminations started back up. And so this fiscal 23 budget is based on Medicaid enrollment of about 1.5 million, but recently, year to date, it's been more like 1.6 million people on the Medicaid program. And so now I will turn it over to Andrew Garrison. He'll be presenting some of the department's personnel data.
Thanks, Ann. So here in front of you in Exhibit 1, what we've done is we've looked at everyone who's in the department's employee system here in January 1 of 2022 and kind of look at this cohort. And first really wanted to see how long they've been with the state. And so as you can see, the largest share of state employees really across all of the different employment groups is those who have been with the department for 4 years or fewer. And we've broken them up into the folks who have administrative work, and that also includes some of the regulatory offices. The public health workforce, parts of different local health departments are budgeted or non-budgeted individuals on the state book. So we were actually able to get some data on them. And then also we do have, of course, the direct care workforce. They're the largest of this group, but those are the folks in our state hospitals and behavioral health facilities. And so we see that, and even moving on with more tenure there with those folks, and then 5 to 9 years. Together, those two make up over 60% of the total MDH workforce. And of course, it does trickle down as people get later into their careers. And then so what we want to do in Exhibit 2 is we take a look at this cohort in 2022, and we then use the same report and we find it from January of 2020. And so January 2020, of course, is before the pandemic. And so we took a snapshot of all the employees on the books there. We were able to look at their employee ID numbers and match them up with transfers. And we wanted to see who was still around in the 2022 cohort that we had just talked about. And of course, as I kind of suggested, given that, it's a less tenured workforce more broadly, we see that there actually is a fairly high turnover rate. So of that 2020 cohort, we see that across the administrative, the healthcare services, and then the public health workforce, we have 10% no longer there in the administrative side, a little bit higher than that in the direct care. But really interestingly, the public health folks who are on the books had a much higher rate, about 1 in 5 or 20%. Were no longer there from that first snapshot in 2020 to that one in 2022. And this is, again, and we kind of mentioned that in that next paragraph, there's some limitations on exactly who we have on the books with those local health department folks. We did think that was an interesting finding, given, what happened in those intervening 2 years and the impact that, of course, the pandemic's likely had on the stress of those jobs on a day-to-day basis. Lastly, on the personnel side in Exhibit 3, we look at the departmental vacancies on a month-by-month basis. And here we just really have good data on the folks with the administrative regulatory jobs or the folks who are working in those healthcare settings, those direct care workers. And although it isn't always the case or hasn't always historically been the case, what we did see is the increase in the vacancy rate for those folks who are working in our state hospitals and state facilities. And what that does is it really drives the departmental wide vacancy rate because they do make up more of the overall positions that we have here. It's about a 60-40 split. And we show that with those filled pin bars below. But with those direct care vacancies being a little bit higher, we are driving the overall departmental vacancy rate right around just under 13%. And that concludes my personnel discussion. Back to Anne for the issues.
So there are 2 issues in this analysis for today. The first one relates to recent state efforts to expand home and community-based services. So this is for people to receive supportive services in their homes rather than in nursing facilities or in state health facilities. This is largely supported through Medicaid waiver programs. You'll see listed here. There are 3 waivers under DDA. There are some other programs under Medicaid, and then there's also the autism waiver, which is administered by MSDE. So first, I'll highlight some of the waiting list and registries for some of these waiver programs. Under DDA, the community services waiting list has declined in recent years, especially from 2018 to 2020. And that's as DDA had brought online 2 new waiver programs to make up its 3. But we did want to point out, though, that they are still keeping a waiting list of over 3,500 people. And so the people on the waiting list do not receive DDA funded services other than targeted case management. The other program we wanted to talk about for waiting lists and registries was the community options waiver. The 2020 Joint Chairman's Report had requested that the Hilltop Institute provide a cost benefit analysis of expanding this community options waiver. And as part of the analysis, Hilltop found that there were 19,804 individuals on the waiting list or on the waiver registry as of September 20th, 2020. But I will point out now it's above 21,000 individuals as of November 2021. However, Hilltop also noted that based on financial and level of care requirements to enroll in the waiver, only a little more than 3,000 people or 15.6% would have been likely to be eligible for the waiver program if a slot was offered to them. Exhibit 5 on page 20 shows another one of Hilltop's findings, which was that Medicaid community options waiver or the waiver program is not typically at full occupancy, and it does not fill all of its authorized slots all over the entire year. You can see on this line, this shows slot occupancy and how it has ranged from 70 to about 80% from 2017 to 2020. The department has described a couple reasons for not filling all of its authorized slots, and that includes by having additional open slots, it prevents them from having to go to CMS for and apply for new slots every time they want to expand the program. And then the department has also described how they're trying to shift from a first come, first served methodology of taking people off of the registry to prioritizing people based on need for services. Recently, there have been a few efforts to expand home and community-based services over fiscal 22 and 23. In terms of the allowance, I'll just highlight that there's $30.2 million in the allowance to expand DDA placements. And then 12.6 million is budgeted in the allowance for 400 additional slots in the community options waiver. And then, as I described before, there's also that 10% enhanced federal matching that was approved in the American Rescue Plan specifically for home and community-based services. And as I had also said, there's budget language from last year that required 75% of this funding to support rate increases. So in the middle of page 22, you can see that DDA is receiving a 5.5% rate increase, BHA is receiving 5.4%, and then the Medicaid programs for home and community-based providers are receiving 5.2%. There are proposed deficiencies that add funding for these rate increases to Medicaid and BHA, but it didn't include DDA. So we just asked the department to discuss its estimate for DDA's portion and then clarify whether the funding for that rate increase is reflected in the budget or not. That remaining 25% of the enhanced match for DDA is specified that it has to be used on mostly grants. It can also be used, I think, up to 5% on administrative costs. But for Medicaid and BHA, the language didn't specify what the remaining funds had to be spent on. And so we also asked the department to comment on its timeline for reinvesting the funding. States are allowed to spend this funding through fiscal 24. And then we asked the department to discuss how they're going to use the remaining 25% of funds in Medicaid and BHA. So then moving on to the second issue for this analysis, we wanted to discuss some of the state's recent trends in maternal mortality rates. Exhibit 6 on page 24 shows the past 6 years of this maternal mortality rate in the maternal mortality review, showing that overall the state has improved on this measure, but what has grown worse is the disparity between the maternal mortality rate for non-Hispanic Black women compared to non-Hispanic white women. In 2013, the difference was about a 2 times difference for non-Hispanic Black women, and then most recently in 2018, non-Hispanic Black women have actually shown rates 4 times higher than those of non-Hispanic white women. And so this is showing a place where the disparity based on racial and on races and ethnicity has grown worse. And then maternal and child health has actually been chosen as one of the state's population health goals as part of the statewide integrated health program, and that's part of the total cost of care model. And so there are efforts recently to address maternal mortality. There's also been state legislation on this, so I'll focus specifically on Medicaid eligibility. Starting in April, the state plans to apply for a state plan amendment that would extend postpartum coverage from 60 days to 1 year postpartum. And so that's one recent effort. And then as part of the statewide integrated health improvement strategy, HSCRC is reserving some of its funding for its regional partnership catalyst program for maternal and child health. And so it'll be $72 million over 4 years, and that will be going through Medicaid and the Prevention and Health Promotion Administration, and we'll be funding some of the programs that I have listed here. But other than that, there is an update on the cigarette restitution fund, but with that, I'll conclude the presentation and I'd be happy to answer any questions.
All right, thank you, Anne. Are there any questions from the subcommittee to Anne? Seeing none, we'll turn it over to the department. With us. Sorry, hang on one.
Chairman, how you doing today, sir?
Hi, how are you?
Can you hear
Let me just introduce all of you. I'm sorry, I had a little mouse trouble there for a second, but with us, Secretary Dennis Schrader, Deputy Secretary Steve Hsu, and Emily Brandenburg, the Chief Financial Officer. So I will turn it over to Secretary Schrader. Apologize for the little hiccup there, and let you take it away.
Thank you, Mr. Chairman. Thank you for having us today. I did want to add that Assistant Secretary Yee will be here. He's going to answer the 2 questions posed by the analysts. I did want to thank the analysts for a very thorough job, and we'll have Assistant Secretary Yee give a quick response to those 2 questions, and then we'll be ready for questions.
Thank you, Mr. Chairman, members of the subcommittee. My name is Webster Yee, Assistant Secretary with the Maryland Department of Health. You have our written testimony before you. Just to quickly touch on those issues that the analysts raised. The first is with respect to the matching funds from ARPA and Enhanced FMAP. Our most recent estimates are included in our November 1st, 2021 spending plan, and it's located on our website. In the written testimony is a link to the plan, and our estimates at the time show that the Department of Health would have about $295 million to reinvest back into the program. Providers received a 5.5% rate increase starting November 1st and retroactive back to April 1, 2021. The amount of money that we allocated to the rate increase is $221 million. With respect to the DDA side of things, we've had 26 meetings now with the Developmental Disabilities Coalition since July of 2021, and also with Secretary Beatty of the Department of Disabilities. The allocation so far is about $50 million in non-competitive grants and 10 to ensure that there's been very close feedback. Some of the meetings have been biweekly, and we believe that things are progressing on track there. In addition, I should note with the second issue, we posted yesterday, we submitted yesterday to CMS our next quarterly proposed spending plan. And we'll provide that information to the analyst so she can provide it to the subcommittee. But the new additional item that we are proposing is, let me get this right, it's including support for certified peer recovery support services for substance use disorder treatment. And we're estimating that this amount will be about $24 million total funds, with about 14.4% federal funds, 60%, and $9.6 million coming from state general funds. And that this would substantially benefit the 63,000 Maryland Medicaid participants in our public behavioral health system with much needed drug treatment services. So with that, we have additional responses in our written, but we're happy to take any questions, Mr. Chairman.
Thank you, Mr. Chairman, and of course we'll be together several more times on the more detailed topics, but we're prepared to answer general questions at this hearing today. So I'll turn it back to you.
Sounds good. Thank you, Mr. Secretary. Are there any questions for the department from the subcommittee? Delegate Valentino Smith.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, and members of your panel. I mean, certainly appreciate how busy you've been since the hit of the pandemic. So just when you come back on the more specific budgets, on the maternal mortality rates, is there a breakdown of whether the mother was covered or not by Medicaid and or by insurance would be helpful to us? And when you talk about there's unfortunate results here, it looks like for the non-Hispanic Black women, also just looking at the Hispanic women themselves, whether they're covered or not would be helpful. And then I think I can catch up everything else when we do the more specific budgets. Thank you. Oh, I guess, sorry, one other question. Mr. Secretary, Deputy Secretary Yee, you talked about sending amendments in on the waivers to CMS. So as you know, I've spent extensive amount of time in the interim with Delegate, and so has Chair Resnick, with Delegate, the Self-Directed Care Work Group, Delegate Young, and have heard that there are amendments that can be made that are where the state's been more strict or not. Just when you come back in, can you update us as a result of that work group and all the work we've done, if you're amending that waiver or not, consistent with the findings of the work group?
Thank you, Delegate. We will take those back and be prepared the next time we come on with those specific questions regarding SDAN, Hispanic women, and the Medicaid or insurance. We'll be prepared for those.
And the waiver application for self-directed. Thank you.
Right. Yes.
Thank you, Mr. Chairman.
Thank you. Any other questions from the subcommittee? Seeing none, I have one or two that I'd like to get the secretary and the department to address. Specifically, if you can address in general terms, obviously we will talk specifics later, but the severe staffing shortage that the entire department is facing, what actions are you taking right now overall to address that, understanding that there are going to be different interventions that are going to be needed depending on the type and skill of the employees that are being recruited. But in general terms, what actions are the department taking to try and fill those much needed slots?
Yes, thank you, Mr. Chairman. And I've asked our CFO to put together a very detailed analysis of that, which we will have in the future, but just a couple of high-level things that we are focused on. For example, within the local health departments, a very high percentage, almost a third of our PINs are within the local health departments. And we have been, if you go back to the Great Recession with the cuts that came there, the local health departments have not really recovered from those cuts going back several years. We have been advocating for and received increases every year for core funding for the local health departments. And this year we were able to get through the governor's budget record local health department increase of $23 million, and we also got a deficiency amount of $9.4 million for FY22. So we're continuing to focus on that workforce. We have had good success hiring people. We have had over 2,000 new hires this past year, 800 of them into state regular positions, about 1,100 contractual, which are due to the surge in the workforce need to support things like our COVID. And we have also managed to maintain good operations within our hospital system. But I'd like to come back at the appropriate meetings in each of the detail sessions and talk in detail about each one of those.
Okay, sounds good. As a follow-up, and we again can have those discussions in detail, but specifically, there is a concern dealing with the professional boards who, as you know, are not funded out of general funds. They are funded by their own licensees' dues, have not been able to hire appropriately, even though that money is special funds and doesn't come out of the department. They have not been able to secure approval for those hires in order to be able to meet the demand within the various licensing boards. So when that budget comes up, I'd like to have a very in-depth discussion about those PINs and how we can get that process moving forward as well. If you could also give the subcommittee an update on the ransomware attack at the department and where things stand now with regard to functionality across the board.
If I could just make a quick mention about the boards, we have actually made proposals, and I think we've talked to a number of folks about this. We would like to offer that the department cover the fixed cost of operating for the boards. that would give them a lot more money from their fees. There is a bill that's been floating around that would do that. We would pay for moving all of the boards, for example, onto DoIT's one-stop portal and take those costs off, and then we would provide all the other fixed costs for the back of the house operations. We really believe that would be very helpful to the boards, and we could talk more about that in the board hearing. As far as the ransomware, we are about 75 to 80% operational. We have workarounds for almost all of the operations in the department. We are about to recover the share drives for many of the staff who need access to their share drives, which will bring us back up to an even higher level of operation. So we're making steady progress, and we're very fortunate that many of the things that we've invested in the last 5 or 6 years insulated core functions from the attack, but we can talk more about that also.
All right, thank you very much. Are there any other questions? With that, we'll conclude the budget hearing for the overview budget for the Department of Health. Just a reminder to subcommittee members that in your packets today and online is written testimony from the department in response to the analyst report, as well as written informational testimony from the Maryland Right to Life. All right, let's move on now to the overview budget for the Department of Human Services, and we'll turn it over to Grace Pedersen and the analysis report. Grace, take it away.
Thank you, Mr. Chair. It's my pleasure to present the Department of Human Services fiscal 2023 budget overview. I'm joined today by Tanya Zimmerman and Samuel Quist, the other Human Services budget analysts. Getting right into it, the budget decreases about 38%, and this is mostly due to the PEBT and SNAP funding that is in fiscal 2022 that's not expected to continue at as high levels in fiscal 2023, with the PEBT program expected to conclude at the end of the current fiscal year. Looking at the breakdown of where the money goes, more than half of it is for public assistance, with the next largest chunk being for personnel expenditures. Looking at the all funds change, the budgets decrease across all administrations except for the Social Services Administration, and then there's a small increase in child support. Looking at general funds specifically, there's decreases in family investment, child support, and administration, but OHEB and social services see a slight increase there. The department receives over $3 billion in deficiencies, most of which is for SNAP and PEBT benefits. Looking at the change between fiscal 22 and 2023, the overall budget decreases by almost $2.3 billion. And as I mentioned earlier, this is due to the conclusion of the PEBT program. So that leads to a $818 million decrease from fiscal 2022. SNAP benefits are expected to be aligned with fiscal 2021 actuals, so that drives a $1.3 billion decrease. Other notable changes in the budget are related to a TCA caseload decline, and then there's limited time funds available from the American Rescue Plan Act. The foster care budget increases mainly due to provider rate increases. Looking at the Office of Home Energy Programs, there's a almost $51 million increase there, reflecting anticipated CEF revenue for energy assistance benefits, but then there's limited time benefits for water assistance and energy assistance in fiscal 2022, and that creates a $87 million decrease from fiscal 2022 in fiscal 2023. Looking at the caseloads, there's notable decreases in TCA, TDAP, SNAP, and the foster care program. Positions, there's 20 PINs that are abolished in the allowance from the working appropriation, but this is only a small portion of the department's long-term vacant pins. The department currently has over 250 long-term vacant pins, which is positions that are vacant for a year or more. The vacancy rate in the department has increased in recent years, seeing kind of an all-time high for the past like 10 years or so in fiscal as of January 1st, 2022. Jumping to the issues, the first one is about temporary cash assistance receipt during and before and during the pandemic. So this first exhibit here is showing how the TCA caseload has increased substantially in the early months of the pandemic and then has remained at an elevated level up until the most recent data available. Looking at the geographic distribution of that caseload increase, some counties really saw notable increases in their caseloads in the early pandemic months. So this data is from April to June 2020, with some counties seeing more than 500 cases added and other counties seeing over a 60% increase in their caseloads compared to the pre-pandemic months of fiscal 2020. So it's a really notable increase there. Something else interesting here is that the demographics of the cases has also shifted. So before the pandemic in fiscal 2020, so that's July to March, almost a third of cases were child only, but then in the early pandemic months, more than 90% of cases had an adult recipient. So this is reflecting the economic instability that families experienced, whereas prior to the pandemic, these families may have been relatively more economically had relatively more economic stability, but the pandemic disruptions really affected the economic stability of those families. And I'll jump to the child welfare issue. This is the second issue we have on page 17. Looking at maltreatment reporting during the pandemic, Exhibit 6 shows the year-over-year change in maltreatment reports. And while there's been a decrease in the number of maltreatment reports, this isn't necessarily reflective of a decreased incidence of maltreatment occurring. And anecdotal reports from some states have even indicated that the maltreatment reports that they're seeing have been more severe because the cases may have been longer from the time of detection. The pandemic effects on family situations have also resulted in some child welfare concerns with employment instability and things like that. Something interesting that's come out of the pandemic is a pretty extraordinary investment in public assistance programs, and a study published in the journal Pediatrics this year looked at states' investment in public assistance programs from federal fiscal 2010 to 2017. So this is before the pandemic, but it found that for every additional $1,000 that states had invested per person living in poverty, this was associated with improved outcomes for child welfare, with a 4% reduction in substantiated maltreatment reports and an over 7% reduction in fatalities. So giving this unique period of investment in public assistance programs, it could be interesting to see what's occurring within child welfare and whether improved outcomes are being seen. So DLS recommends to request data about the number of maltreatment reports, specifically neglect reports, and to see whether those the reasons for neglect are associated with economic stability factors like families' inability to afford necessities like diapers or childcare, things like that. The third issue we have for you is about the temporary assistance for needy families funding, and Tanya Zimmerman is going to present this.
Thank you, Grace. If you look at Exhibit 7, this provides an overview of the amount of TANF funding that the state receives, as well as spending and the amount of balance that it carries forward from year to year. So the basic TANF block grant, the states received about $228 million in each year since fiscal 2017. Before that period, they received just a slightly higher amount, but relatively the same amount. Also, since the Great Recession, the state has received what's known as contingency funds. Those are available to states if meeting certain criteria related to unemployment or SNAP caseload growth relative to what the caseloads were in 1994 and 1995. If the criteria remains unchanged, the state would be expected to continue to qualify for those contingency funds for the foreseeable future. In addition, the stimulus funding has made available a kind of a one-time additional amount of funding known as the Pandemic Emergency Assistance Funds. And those are available for some administrative costs as well as kind of short-term non-recurrent benefits. So when this analysis was presented to you last session, the department was expected to fully utilize the TANF balance by the end of fiscal 2021. However, during session, the American Rescue Plan Act was passed, and that brought about some changes to the TANF spending plan. Supplemental budget number 5 had a deficiency appropriation for fiscal 2021 that replaced $100 million of TANF spending with state fiscal recovery funds from the ARPA. And in addition, replaced $40 million of TANF with ARPA funds in fiscal 2022. After the budget was enacted, federal guidance indicated you could not use the state fiscal recovery funds for costs incurred or costs paid out before March 3rd of 2021. And so they could not fully utilize the $100 million. They were able to utilize $50 million in fiscal 2021, but not all 100 million. And the Department of Budget and Management indicated that the additional 50 million they could not use in that year would instead be used in fiscal 2022. And a proposed deficiency appropriation effectuates that change. But as a result, instead of fully utilizing the balance in fiscal 2021, they had a balance of over $35 million at the end of that year. And that would be expected to grow to over $125 million in fiscal 2022 as a result of the additional fund swap. In fiscal 2023, TANF spending returns to more typical levels, and while they retain a significant balance, it does decrease slightly. So this high balance allows the department flexibility to increase spending on programs, but it also allows the department to have flexibility to use these funds in future years when general funds are less available. Exhibit 8 presents information on the spending of TANF in recent years and the proposed budget. In fiscal 2020, the spending on cash assistance was the highest since fiscal 2015. And the overall spending of TANF was the highest since fiscal 2011. And this is largely due to the sudden rapid increase in the TCA caseload at the onset of the pandemic. Because of the available ARPA funds, the spending on cash assistance decreased by over 30 million in fiscal 2021 compared to the prior year. And the overall TANF spending decreased. The decrease in spending on cash assistance in that year was partially offset by higher than expected spending of TANF for the foster care maintenance payments program. In fiscal 2022, spending on cash assistance declines to much lower levels, again, because of the higher fund swap with the state fiscal recovery funds. The overall level of TCA spending is still expected to be the same level. It's just the source of the funds. In fiscal 2023, it returns to more typical level of TANF spending, but the spending on foster care maintenance remains high. As you can see in Exhibit 9, this breaks down the spending of the fiscal 2023 allowance by purpose. So cash assistance comprises 43% of the allowance from TANF. The next largest share is for foster care maintenance payments of 13%. And at nearly $35 million, this would be the highest level since fiscal 2002. If you go to the next exhibit, Exhibit 10, this shows kind of some historical experience with the share of TANF spending on cash assistance. And you can see that fiscal 2023 is in line with most recent years, with the dips in 2021 and 2022 due to the ARPA fund replacement. And the final exhibit reflects the TANF maintenance of effort spending. So this is the spending that's required for the state to receive the block grant as well as the contingency funds. The state has to meet certain levels of spending, which are kind of identified at the bottom portion of the chart. As you can see at the top portion of the chart, the state is spending well more than is required to meet that maintenance of effort, so they remain in good position to continue to meet that required level. The couple notable things is the maintenance of effort spending of fiscal 2021 was over $100 million higher than the prior year. And that's primarily driven by two factors, which is the higher use of general funds to support cash assistance, and also the expansion of the refundable earned income tax credit that was passed last session. And that is all I have for you, and I'll turn back to Grace for the final issue.
Thank you, Tanya. The last issue DLS has for you pertains to the relocation of DHS's headquarters to downtown Baltimore City. The administration has prioritized moving state agencies from the State Center complex to the downtown Baltimore City Central Business District. DHS current headquarters is already located within the proposed relocation boundary, as shown in Exhibit 12 here. But while the stated goal of the relocation is to revitalize the central business district, since DHS is already located here, it's unclear how much revitalization potential there is from the move. However, over 70% of DHS's workforce could either telework or work on a hybrid schedule during the pandemic. So there could be other reasons for the relocation. So DLS is asking DHS to comment on that. That concludes my presentation. I'd be happy to answer any questions.
Thank you, Grace. Are there any questions for the analyst? Seeing none, I have one. Grace, can you comment as to the status of MD Think? Is it fully rolled out? Is there any budget request for it this year? I understand that it was down last week or some days ago, and the department was unable to utilize it in any way. So just wanted to get a status update of where we are with its rollout, and if there's a budget request for additional money for this year.
Thank you for that question. So this will be talked about at length in the DHS administration analysis. The MD Think project is expected to conclude development in fiscal 2022. There is funding in fiscal 2023 for Do It oversight in the budget, but as to any pauses in operations, I think the department would be better able to comment on that specifically.
Yeah, I wasn't asking you about the process and operation. I just wanted to know where we were in rollout and what the current budget request would be for the upcoming fiscal year. So thank you for that. Any other questions? Seeing none, we're going to go to the department now. Sorry, I don't have it up. I should have it up. We have, wrong page, there it is. We have the Secretary, Secretary Padilla. We have the Deputy Secretary of Operations, James, Deputy Secretary of Programs, Kibret, and then Chief Financial Officer Chipungu. Please kick it off, and look forward to hearing your presentation.
Thank you, Chairman Resnick and members of the committee for the opportunity to discuss the FY 2023 budget allowance for the Department of Human Services. In addition to the team members that you just noted, I want to say that I also have in the room Denise Conway, Deputy Executive Director, Social Service Administration, and we also have other members of our leadership team are also with me. I want to take the time to thank Tanya Zimmerman, Grace Pedersen, and Samuel Quist for the comprehensive and concise analysis of DHS's budget. They're a pleasure to work with, and we appreciate all their support. You have my written testimony, which I won't repeat here. Before I address the 4 issues in the analysis, I want to take the time to share some of our accomplishments. In the Family Investment Administration, Maryland families continue to face significant challenges during the second year of the COVID-19 pandemic, and DHS has been there to help. Our mission has never been more important. Let me take this opportunity to thank the dedicated, hardworking staff of DHS and our 24 local departments of social services. They have gone above and beyond to ensure that Marylanders receive assistance and benefits to weather this pandemic and continue to do so today. The Family Investment Administration now manages over 770,000 cases across all programs. FIA safety net programs are serving 300,000 more individual recipients compared to pre-pandemic caseload levels. This represents a 35% increase in the number of cases served versus pre-pandemic levels. The pandemic EBT program administered by FIA in coordination with the Maryland State Department of Education is providing $1 billion in benefits to more than 550,000 children who were eligible for free or reduced price school meals, but unable to access those meals due to COVID-19 remote learning. We continue to distribute the emergency allotment benefit as part of the SNAP program, resulting in over $1 billion in additional benefits provided to active SNAP recipients. TDAP recipients saw monthly benefits increase from $243 to $256 on July 1st, 2021, and receive another increase to $328 on January 1st, 2022. This increase now aligns the TDAP benefit with equivalent TCA benefits. In the Social Service Administration, we have continued Family First implementation efforts to transform our child welfare system to focus on families and build a prevention-based approach that emphasizes partnering with children and families. Our transformation is focusing on enabling families to access evidence-based prevention services to keep them safely together, establishing qualified residential treatment programs to provide high-quality therapeutics intervention for youth who need short-term residential care, and implementing the new assessment process to determine the appropriate level of care for children and youth who are entering care. As of December 31st, 2021, we had more than 4,300 children in out-of-home placement. The majority of the children, more than 3,000, are in family care settings. The other youth are placed in group homes, independent living, residential treatment, or other settings. Moving on to the Child Support Administration, the department collected and distributed $543 million in child support last year. Of that, $160 million was distributed to families previously receiving TCA, reducing the likelihood that those families will become dependent on the state for financial stability. As of the first quarter of federal fiscal year 2022, $124 million was collected and distributed in child support. The amount collected per case has increased by 8% or $243, rising from $2,975 to $3,218, despite the number of child support cases decreasing by 8%. The intercept of video lottery winnings authorized by HB 907 has allowed the department to disperse $4.9 million in gaming intercepts to pay past due child support. The Step Up program continues to be a success. This program provides eligible, unemployed, or underemployed non-custodial parents with assistance in obtaining employment that will enable them to achieve economic self-sufficiency and to meet their child support obligations. And on MDThink, in 2018, the MDThink Cloud Platform was launched. In 2020, we implemented the child welfare module of the new Child, Juvenile, and Adult Management System, or CJAMS, and the Adult Services module launched in 2021. And in November 2021, I am pleased to report we completed the statewide deployment of our new eligibility and enrollment application, or E&E. The E&E application support programs such as SNAP, TCA, TDAP, long-term care, and other Medicaid eligibility system. E&E is critical to the delivery of our economic assistance benefit. The deployment of both CJAMS and E&E during the COVID-19 pandemic, while the DHS and MDThink staff were teleworking, was a major accomplishment and reflects the skills, innovation, and dedication of our MDThink team and our frontline workers. That concludes my opening remarks. Now, with your permission, I will move directly to the issues in the analysis. In response to issue 1, regarding the department will publish monthly maltreatment data through December 2021. The department anticipates publishing the maltreatment data through December 2021 by the end of April 22. On issue 2, regarding insights of the impact of the pandemic on child welfare caseload, the department is seeing a return to pre-pandemic levels of suspected child abuse and neglect cases. The trend in the number of cases directly correlates the schools' return to in-person learning. We will continue to monitor, of course, the current trend. On issue 3, the department, to the extent possible, will work to address the proposed recommendation. On issue 4, regarding the anticipated timeline for relocation and benefits expected to be achieved with this relocation, we are on target to relocate in the fall, winter of calendar year 2023. The benefits to be achieved from relocating are structural and environmental health benefits, workplace safety and workability benefits, workplace and technological benefits, and workspace efficiencies. This concludes my testimony and response, and I will be happy to address any questions the committee may have. Thank you so much.
So open up to questions. Any questions for the department from members of the subcommittee? All right, we'll start with Delegate Henson.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for your presentation. I believe the statistic that we got from Ms. Pedersen was that 70% of the department's employees were teleworking or telework eligible throughout the pandemic. What, if any, long-term impacts will that time of telework have on the department's operations?
I can say that we have been very successful in implementing telework in a hybrid model where employees are expected to telework some days and other days come into the office. If you review the data of our ability to deliver services, that has not had any negative impact in our ability to continue to deliver services timely. So I can say that if anything, it has helped us in our ability to retain employees during the pandemic. As you all know, the workers, just as anybody else, have also struggled during the pandemic and have had to manage having children at home and having to deal with the pandemic. We have been very flexible in allowed to telework so they can successfully accomplish both. So I haven't seen any negative. If anything, it has been very positive. And the local assistant offices I want to be clear that we are open. Our offices are open, fully staffed, and people that do walk in to our offices are being served as they were served pre-pandemic. Thank you.
Mr. Chair, may I be permitted to follow up?
Please.
Thank you. Has it had any impact on, you mentioned that it was a positive on being able to retain employees. Has it had any impact on the way you view some of the long-term vacancies, whether eliminating the need for certain positions because telework now has, taken away perhaps a front desk person here or there when people are working at home? Or has it had any impact at all on the long-term planning as well in terms of the space that you'll need to accommodate the workforce and how you are structuring work assignments?
Yes, it has had, because when we look at the relocation and completed space utilization, we determined that our space needs would be less, because we would be able to, first the hybrid and second the hoteling, where because employees are not here every day, a space could be utilized by one or more employees at the same time. We did with the Department of General Service an in-depth space utilization, and that's when we came with a space footage that was needed for the new building. In terms of the retention and has it had an impact on the way that we do the work? It allows so much flexibility. And one of the things is that the work needs to be done. When it's done, that teleworking creates that flexibility, right? If an employee is more available during a certain time and non-traditional time to do the work, it can be done during that non-traditional time as long as the applications are processed timely and correctly. So it really allows for a lot of innovation. This is really new for our department. And as we are going to be reviewing and identifying needs for changes or need for perhaps be more clear on how we are going to be asking our employees to account for their time and for the work they do. But it has been something as so far very positive, not only for the department, but also for the employees.
Thank you.
Thank you. Delegate Valentino Smith.
Thank you, Mr. Chairman. Thank you, Madam Secretary, and your staff, and again for the work that you've all been doing and committed to through these difficult and challenging times with the pandemic. I don't want to belabor this hearing, but just put you on notice with respect to SNAP, and we heard and saw a lot about it in this overview and the supplemental SNAP program. As you know, I've been working with your office since November, trying to get some data and understand the supplemental SNAP program for seniors. And there is a House bill hearing, House Bill 456 next week. So I would like to talk to you or the department in more specifics about the supplemental SNAP program and seniors before that hearing, or at least get some of the data that I've been requesting. And then number two, I know we've been talking about proposed legislation that I'm working on with respect to workforce experience. And I think there's some general references to workforce and workforce expenditures in this general overview. But if before that budget with temporary cash assistance, I could get some of the information that I've been asking about the WEX participation rate and about the workforce participation rate and about the outcomes for the TCA workforce and the subcontractors. So that all would be very helpful as we prepare to go into more specifics on this. Thank you, Mr. Chairman.
Thank you. Any additional questions from the subcommittee? Not seeing any. I'd like to follow up on a couple of points. First, if, just like the question I had for the health department, the Department of Human Services is experiencing dramatic understaffing. That's been going back, not just this year, but going back several years, especially in Social Services Administration. I'd like to get a sense from you as to what you are planning to do in the coming weeks and months to fill those vacancies as quickly as possible and train those new employees. If you can please respond to that, I would appreciate it.
Thank you so much for the opportunity to respond to that. And as the agency head of this department, and it was stated that this has been a trend and an issue that has been occurring for the past 10 years. So one can say that an administrator then have to look at this in a very different way. There's some that if you follow the trend, one could say that it could have is somewhat predictable because it has been happening and it has been a challenge not only in Maryland, but at the national level. So what we have done, I want to address the social services, the child welfare workers. I asked for an analysis, and what was brought to me is the child welfare workers, we go by Child Welfare League of America caseload standards. And what that tells us is the staff that is needed based on our caseload, the positions filled, and are we meeting those standards? And for 2021, the staff needed was 1,129 workers, and the position filled in our department in social services is 1,415. So there's a difference of 285, saying that we are meeting that standard, and we have the adequate staff in the child welfare for us to meet the demand and the services provided. Now, that's meeting the standard. What as an administrator, then I have to shift and look at meeting the standard. That's a general number, but do I have it's a balance? Do I have the workers in the right county that would require for me, that I would require to do the work? Or do I need to shift? Do I need to do a full analysis of how can the work be done differently if I have the tools, I have the personnel, but it seems like it's kind of balanced. What I'm hearing is in some counties, I have more vacancies than I should, but in other counties, I'm meeting the demand. So that's some of the analysis that I'm doing. But at the same time, I have met with my director of human resources, and I have asked him, have a very aggressive hiring campaign. At the same time, work with the academia to see if some of the requirements, the qualifications could be revised so we can attract more personnel in that area. And then in the Family Investment Administration and child support, what we have done, going back to preventable, because I think in general, we can all agree that this is not going to go away. I've been reading a lot of articles about the resignation that is taking place in the United States right now. So as an administrator, I need to then evaluate, is there a different way of doing the work? I want to continue to focus on meeting the family needs. And in doing so, how can I then do the work differently and take advantage of the technology that we in the Department of Human Services have now that could help us in meeting the needs of the families? And I can elaborate more, but this is some of what we have done.
Well, we're going to be discussing this issue a lot more as we move forward into the more detailed budgets of the different agencies and administrations. But yes, there is, a severe concern on the part of both the legislature, but also frontline workers who, as early as today, were telling me how in your department they are overworked and staffing is not meeting their needs. So that's a discussion that we're going to have more as we move forward into the specific administration budgets. The second question I had deals with an issue that I think you are very familiar with. We've had this discussion many a times. It's with foster children in hospital overstays. As you now know, I have a bill to deal with that issue submitted into the legislature. There will be a hearing coming up in a few weeks. I'd like to get a sense from you if any progress has been made since the last time we spoke in decreasing the number of kids in hospital overstays and finding more permanent placement for them, whether it is in residential treatment facilities or foster homes, or if we are opening any additional facilities to deal with their specific issues.
Thank you. We have made a lot of progress working with our sister agencies and the Children's Cabinet and in coming up with a plan to develop capacity for on children in hospital overstay. As I have stated before, this is an effort that it didn't happen overnight, and it's not going. The solution is not going to be overnight. It's going to take time. I can say we have been working. This is something that we talk about and meet and come up with strategies almost on a weekly basis, and not just my department, the other departments as well. The department is reviewing the bill that you submitted, and we would be prepared to respond and take a position accordingly. But we have worked on our plan that we developed last year, that I believe it was shared with your agency, and we remain on track with what we said we would do in that plan.
Well, we will continue to discuss it. We'll obviously have a budget hearing. Again, the information that I'm getting from hospitals in this state did not match the information I got from the JCR report that you all submitted as to the number of children who are in hospitals, the number of days they are in overstays, and how they are dealt with once they are picked up. So we will continue to have this discussion, and I hope that we will come to some resolution to it sometime in the next, few months, if not by the end of session. With that, any other questions? Seeing none, I want to thank the department, and we are going to move on now to the budget for the Maryland Health Benefit Exchange. We will start with, we will start with the analyst report, and that would be with, where am I? There I am with Andrew Garrison and his analysis, and then we will move on to the department. Just a quick word, there was no one signed up to testify from the public for the Human Services Department, but there is written testimony in your folder. So we'll go from there, and we will kick it away with Andrew. Thank you.
Thank you, Mr. Chair. You all should be seeing the budget for the Maryland Health Benefit Exchange on your screens. And what we have to do with the benefit exchange, of course, is the state agency that operates the Maryland Health Connection, the state-based marketplace for Marylanders and small businesses to find health insurance plans. And what we're going to be talking about today, largely, we can actually show on this first screen through the increase that we're seeing about $50 million. And there's two things that are driving that in the fiscal 23 allowance. The first of which you see a little blue sliver on the top there. That's from the young adult subsidy. The young adult subsidy is actually in effect for plan year 22 as well. My office did just receive a budget amendment for that, so that's not quite reflected yet in the 22 working, but that is ultimately going to wash out over those 2 years of its implementation. And then the reinsurance fund is also that large purple chunk that we're seeing there. And the reinsurance funding, which includes federal pass-through dollars. And we're going to be talking about that a lot more in depth. The green and yellow bars are then sort of the operating budgets of the exchange. And as you can see, those are fairly flat throughout this budget. So we're only going to be touching on them briefly here in Exhibit 2. And what we show here is, again, just focusing on those operating dollars. They're split pretty much 50-50. Half of it is going towards the actual mechanics of the exchange of the Maryland Health Connection and various improvements to that platform. And then we also have other components that are going to personnel, the call center to help people navigate accessing insurance, and marketing and outreach, trying to increase open enrollment and enrollment in the Health Connection. Just to highlight that change, that $50 million we're talking about here, that is entirely largely attributed to those federal pass-through dollars, and then that young adult subsidy that we expect to ultimately be netted out once we adjust for that fiscal 22 budget. First, turning to the reinsurance program, what we have here is sample monthly premiums to kind of look at what the impact of the reinsurance program has been. And so a couple of things we want to highlight here. First is that we are seeing an overall kind of stabilization around the lower values from the last plan year. We do see modest increases, but there still aren't to the point of where they were prior to the reinsurance program, really, I think, showing the impact that this program has had on stabilizing rates within the insurance marketplace here. We are also going to talk briefly about high deductible health plans. And in the prior JCR, there was a request to look at the prevalence of high deductible health plans as defined by the IRS. And so using that definition, what the exchange did for us in the JCR report was they looked at how common they are across the different metal levels that were offered in the state. I will note here, as you can see on your screen, that only goes through 2019. The exchange notes in that report that obviously 2020 had some challenges in terms of forecasting the market with the pandemic. And so we really are just kind of looking at 2019 and prior to that. But first of note is all of the different plans below gold level exclusively do meet the definition of a high deductible health plan as defined in the report. And then interestingly, those gold level plans started off having being it's fairly rare to be a high deductible plan, but in 2019 have increased to now be the majority of them. I think that's 6 out of 8 that we're seeing there, or pardon me, 4 of 6. And so what we're doing here is we do have a note asking the exchange to comment on the increasing share of those high deductible health plans and any steps to be taken to reduce their prevalence in that individual market. Turning now to the reinsurance fund. As you all know, the reinsurance fund and the reinsurance program, as we talked about before, is funded through 2 different sources. One is the federal pass-through dollars, and the other is through the state reinsurance fund. And that state reinsurance fund is funded through a provider assessment on health insurance carriers in the state. And so far as the reinsurance program has been in existence, the amount of federal dollars that have come in for the program have actually outpaced what the program needs are. And that's what we're showing there for those first 2 years in calendars 19 and 20. And then in calendar 21, the initial assessment and distribution was going to be, or anticipated distribution was going to be below what the planned expenditures were for the reinsurance program. However, due to provisions in the American Rescue Plan Act, or ARPA, the federal pass-through dollars have actually gone up. And so still allowing those federal dollars to continue to cover the program costs. Interestingly, the initial projected impact of ARPA was actually much lower than what ended up happening in 21. So what DLS did in 22 here is we estimated that same difference is about $107 million from the July forecast into what actually ended up happening in September when those funds got distributed. And so we tacked on that extra $107 million. That's the amount in 22, and are anticipating that that ARPA impact is going to continue into 22 and help make up some of that difference there that we're seeing between what we're expecting from the feds and what the reinsurance program is actually going to cost. We aren't considering any ARPA benefits or impacts from ARPA in those out years because as of right now, they're not necessarily in federal statute. And as you can see, the impact of those ARPA dollars in 22 really do make a difference into how much of the coverage of the total reinsurance program cost we're able to pay for with those federal dollars. And that is important because that does impact when we end up needing to tap into the reinsurance fund, which, as mentioned before, is a special fund that has been created that provides through provider assessments. It started off at, I think, at 2.75%, and it's now at 1% on insurance carriers in the state. There actually is a bill as introduced. It was House Bill 413 that would continue this through calendar 28, and so continue in funding for the reinsurance program. But right now we're focusing on the fund balance through 23 because that is what's currently in statute. And so what we're seeing here is the first time we anticipate the state needing to tap into the reinsurance fund for the reinsurance program is going to be in calendar 23 or sometime around fiscal 23. And that's because of the federal dollars surpassing the reinsurance fund cost that we were showing previously. Any sort of excess federal dollars can be rolled over into the next year for reinsurance costs only. And we're also on here accounting for some of the other planned uses of the reinsurance fund. Was some planned transfers to Medicaid in there, as well as support for the Community Health Resources Commission and the Health Equity Resources grants. We're also coming out of this fund at different points, and some of that does continue into the out years as well. And then we've also placed the $20 million from the young adult subsidy here. Of course, as we showed previously, at some point we do expect the federal pass-through dollars to be less than what we're going to be spending on the reinsurance program. And that is why having the provider system continue would help maintain the fund balance. But right now, looking at what we know right now in front of us for 23, we are still, I think, having a sufficient fund balance in that reinsurance fund on the state side of things. On the reinsurance fund, there was a JCR report last year about not only the reinsurance fund, but the program itself. DLS is making a recommendation for continued reporting on that through committee narrative. Further, something that was also last year is to have any notification provided if the exchange submits for any particular state innovation waivers to continue the reinsurance program. And so we are including a recommendation for that as well. The last thing I want to touch on is some of the pieces of open enrollment and the Marylanders enrolled in qualified health programs, qualified health plans through the exchange. Noting that the young adult subsidy is going to be targeting folks in your second and third bars on your screen. So those under 35, we are highlighting that any increases that we have seen between plan year 21 and 22 are largely in those older young adults, so to speak, and they have a lesser subsidy than those folks in the 18 to 25-year-old range. Also in plan year 22, open enrollment has continued to be extended now through the end of this month. And so we are seeing increases largely throughout. Plan year 21 was a record for Maryland Health Connection enrollment, and right now 22 is well on track to beat that, again, given some of the extensions that we've seen throughout the open enrollment period. And lastly, while we're talking about enrollment increases, back in February of 21, the exchange put together a report looking at uninsured rates, particularly in kind of a post-pandemic setting, thinking about individuals who may have lost coverage, lost employer-sponsored coverage. And then so what we did here is we put that on the y-axis on a jurisdictional basis. And then on the x-axis, we plotted their open enrollment increases from this most recent enrollment period. And we have on the kind of quadrants divided what the statewide rate is. So anyone who's on your upper left-hand side, those are folks who had a relatively high uninsurance rate at the time of the exchange's analysis, but unfortunately had kind of a lower open enrollment, and we do see a clustering around there, particularly with some Western Maryland jurisdictions. And then on the bottom right-hand side, we'll have the folks, the jurisdictions rather, that have an a higher increase in open enrollment relative to the rest of the state, but also had a lower uninsurance rate. And that really is kind of the two poles in which we're looking at for enrollment increases. We have relatively few jurisdictions that had a relatively high uninsured rates, and then also a higher open enrollment, unfortunately. I will also, of course, note that Maryland traditionally has a fairly low uninsured rate. And so broadly speaking, the enrollment in exchange is beneficial to providing coverage to those who need it. And again, this was a record year for open enrollment that we are expecting to continue with the extra 26 days of open enrollment right now for plan year 22. Lastly, again, here's kind of the summary of DLS's recommendations. They include any notification of state invasion waivers, and then that continued reporting on the reinsurance program, as well as possible funding needs for it. That concludes my presentation, and I'd be happy to take any questions.
All right, thank you, Andrew. Do we have any questions for about the analysis for Andrew? Seeing none, let's turn it over to the department. We have Michelle Eberly, the Executive Director, Mr. Andrew Ratner, the Chief of Staff, Ms. Johanna Fabian Marks, the Director of Policy and Plan Management, and Mr. Tony Arminger, the CFO. Ms. Eberly, do you want to kick it off? I don't know if anyone else is speaking other than you, but
absolutely, I'll kick it off.
Go ahead and kick it off.
So good afternoon, Chair Resnick and Vice Chair Valentino Smith and committee members. We appreciate the opportunity to address the committee today. And we have much gratitude and thanks for Andrew Garrison for his thorough analysis of the MHBE budget. He's new to us, relatively new to us, and he just has dug in and got all the information. We appreciate his tenacity and his close look. As you indicated, I have other colleagues here today that will be available for questions as needed. You do have our written testimony in front of you, and in addition to that, we did include this year a presentation we just gave to our Board of Trustees in January on the open enrollment at that time, before it was extended, on the results of the open enrollment period. I don't intend to go through that presentation, but it does capture our very successful enrollment period for commercial health and dental plans purchased for the 2022 plan year. I do want to note in our budget hearing that our presentation often focuses on our commercial health plans and commercial dental plans. But as you're aware, the MHB budget also supports over 1.2 Medicaid members that enroll year-round. And we provide them with eligibility determinations, enrollment services, provider selections, customer service, in-person in our call center, outreach efforts, and our appeals processing for cases, among other full service operations. So we tend to not talk about all that work we do for those 1.2 million members over that now, but I really wanted to point that out. The mission of MHB is to improve the health and well-being of Marylanders by connecting them with high quality, affordable health coverage through our innovative programs, technology, and consumer assistance. You'll see from that presentation that we're doing just that. A major component of what has allowed us to offer affordable health coverage is the innovative reinsurance program, which the legislature helped us put in place in 2018. And as you know, we're one of the first in the nation and the largest to date of this type of program. In 2018, we were facing individual health insurance rate increases of up to 50%. Rates had already risen 166% since the 2013 implementation of the Affordable Care Act. Immediately after the implementation of the reinsurance program, we saw rates starting to go down. And in fact, over a 3-year period, they fell 32%. Our goal of that program was 30%, so we even achieved beyond that goal. The reinsurance program, along with our technological innovation, our focused outreach and marketing efforts, and our consumer-driven customer service, have afforded many more Marylanders with health insurance. And as Andrew said, in fact, in 2022 for this plan year, we have over 181,000 consumers enrolled through the exchange. That's up 9% from 2021. And in addition to that, over 60,000 individuals have enrolled directly through insurance carriers in the individual market. So that's nearly 250,000 people that have been able to obtain high quality, affordable health insurance, an increase of 14% in 2020. Why the tax credits and the subsidies are so important. Again, many of us who get our insurance through employers, we don't recognize how much of that healthcare coverage is subsidized by our employers. They pay a good percentage of that cost. That cost gets shared with the rest of the world, their community, in terms of product costs, et cetera. If you're an individual purchasing your own health insurance, you don't have that employer to help subsidize that cost. So these tax credits and the young adult subsidy, which we've been able to afford, really have made it very affordable for folks to purchase health insurance. With the American Rescue Plan funds this year, a big change, and Andrew noted it, we've seen significant increase in particularly over 50 enrollment. Typically what had happened, we had what we call the 400% FPL cliff, where once you met that certain dollar threshold, you were no longer eligible for tax credits. That cliff has been eliminated, and even folks that are over that threshold income may be eligible for tax credits. So we have found older age, higher income folks be able to get health insurance. Maryland, in fact, has the most affordable gold and bronze plans in the nation. Our average rates are the most affordable in the entire nation. Our silver plan is the third most affordable in the nation. And that's just terrific. That has really allowed us to bring healthcare to folks. Through the reinsurance program, we reinvested $20 million of the assessment money into the young adult subsidy to better attract young folks into health plans. And as we know, in insurance risk pool, the more young, healthy people you have to offset, the more high user consumers, just brings the total cost of healthcare down for everyone. Our growth in the last year for that 26 to 34 year old population grew 9%. Stable rates have also helped us shrink gaps in health equity. These are targeted areas that we've focused on for several years. Enrollments of Black and Hispanic residents who lack health insurance at rates higher than the general population grew by 10% and 13% respectively for 2022. Now, when we look statewide at where we see the gains, they're all across the state. The largest enrollments occurred in Carroll, Hartford, Anne Arundel, Baltimore, Prince George's, Howard, Calvert, and Charles counties, where they all had gains greater than 10%. The stabilized and more attractive consumer market propelled business and economic growth for all three carriers that participate in our marketplace. CareFirst saw a rise of 5% in their enrollees, Kaiser Permanente 3%, and United Healthcare, which expanded statewide this year, had a 472% increase in its first year in enrollees. This increase has occurred year over year, thus creating better business opportunities for these carriers and encouraging more economic growth. One concern of health plans continue to be the cost of the deductible. And as Andrew said, we submitted a JCR report on that. And it's a little bit of a challenge for the exchange because the IRS defines what constitutes a high deductible health plan. It also allows, if you have a high deductible health plan, other things such as health reimbursement accounts, et cetera, to be used with those. The established minimums for the high deductible health plans for 2022 are $1,400 for self-only plans and $2,800 for family plans. So those are low amounts for qualifying as a high deductible health plan. Using that threshold, as Andrew indicated, only 5 of our 34 plans offered qualify as a low deductible health plan. Now, what's interesting to note is that 10 of those plans are silver plans. And those deductibles range between $2,250 and $6,000. But what's of interest to note on those is that most silver plan enrollees qualify for cost sharing reductions that further reduce their deductibles. So it's, again, a little misnomer when if you're just looking at that deductible, as there's other things that are factored in. Now, however, having said that, we continue to see significant growth in the plans at the metal levels that offer our lower deductibles, silver, gold, and premium across the board. We implemented value plans several years ago, and the idea with that was we heard loud and clear from consumers, we look at premium amount, we look at deductibles. So we really worked on and continue to work on value plans that offer lower deductibles. For 2022 enrollments through January 15th, the platinum enrollment, now this is our highest plan, platinum enrollment growth was 60% up. Our gold enrollment grew 26%. What that means is that plans have become more affordable, so people are buying up in coverage. They're buying up into a lower deductible health plan because the total cost of that premium has come down. So instead of paying a lower premium, seeing a silver plan at $2,500, they might pay a little bit more and move into a gold plan with $1,000 deductible. That's one of the ways that we continue to look at these and look at how can we deliver products that are affordable for Marylanders. I do want to note that as an exchange, we have limited ability to adjust the cost sharing parameters, the deductible, et cetera. There is, by federal standards, what's referred to as an actuarial value for each plan at each metal level. We often refer to this as the balloon effect. So if you lower the deductible, you might have to increase a co-payment or a co-insurance or other out-of-pocket expense. So it's a constant juggle that the carriers do every year when they're looking at what types of products to put on the market to meet that federally mandated actuarial mandate and to keep those out-of-pocket costs low. And we work with the carriers and with our stakeholders to look at the value plans that are on the exchange to make sure that we're delivering the most affordable coverage, the highest quality coverage for our consumers. Just some final response, the exchange will continue to look for ways to offer high quality affordable health plans, and we will continue to report to the legislature on the reinsurance fund and the program, including impacts on premiums, the possibility for continued implementation for the provider assessment, and any further necessary action that's needed to fund the reinsurance program, including submission of 1332 waivers. And with that, I'm happy to take any questions.
Thank you, Ms. Eberly. Any questions for the department? Delegate Valentino Smith.
Thank you, Mr. Chairman. I just wanted to take a point of personal privilege. It's not a question, but what I really wanted to do was commend the Maryland Health Benefit Exchange. I don't know that we get a chance, and Ms. Eberly herself, to recognize behind the scenes how much work they do. But in the interim, we, along with the Senate Budget Committee, gave them a pretty significant JCR to write for us with respect to expansion of coverage to individuals that are ineligible for Medicaid and qualified health plans. And they sent us back a very robust JCR report that clearly took a lot of work and a lot of research, but is extraordinarily helpful and is the basis for 2 pieces of legislation that are in the HTO committee. And Ms. Eberly went above and beyond by returning calls at night and within minutes notice sometimes when we were working on this JCR report. So I know in the end, as a subcommittee, we do ask the departments to do a lot in the interim, but this particular one was a lot of work and very helpful. And I just wanted to commend her and the MHPE. Thank you, Mr. Chairman.
Thank you. And I would say ditto to that as well. So any other questions? All right, seeing none, I think we are, and I believe Delegate Young had to go to a bill hearing. So I believe with that, we are done with today's bill hearings. I'm sorry, budget hearings. And we'll be meeting again. June, when are we meeting again? I have to take a look.
Next Wednesday.
Next Wednesday. All right, sounds good.
I'm sorry, actually, excuse me, Monday and Wednesday. So
Monday and Wednesday. All right, so we're gonna have two budget days next week, multiple budgets on each day. Look forward to seeing everyone. Thank you again for the testimony, and that we are adjourned.